Okay, perfect. All right, so let's get started with the talk today. So today we'll be discussing the approach to chest pain in the emergency department. Um, so first thing I wanted to do was introductions, which we've done. And then we're going to do a lecture portion for the first approximately 20 minutes, which is the approach to chest pain lecture. And then we'll go through a case study and then do some practice questions and then have a few minutes if you have any questions that you would like to go over. So, in terms of the general approach to chest pain in the emergency department, what should we be doing every time a patient comes in with chest pain? What we're trying to do is create a model that can be used every time. And this is more of a mental model that you can use so that you aren't missing any steps when you're going through evaluating a patient with chest pain. So, what are the components of the history that we should be asking? What are some important physical exam components that we should be including in our evaluation? What's the relevant differential diagnosis that we should keep on our mind in the emergency department? And then we'll briefly go over some tools that can be used to help in coming up with what your workup plan will be. So for the model of evaluation of chest pain in the emergency department, of course, as we had kind of started with the cases last week, we always start with our A, B, C, D, and E. So in terms of airway, we want to make sure that they're protecting their airway. And we really do this by seeing if the patient is able to speak as they would normally be able to. Then we move on to evaluating their breathing. Is there any difficulty with their breathing? Are they breathing really quickly? Are they using their belly to be breathing? Are they using any accessory muscles? Is there any cyanosis that's present or blue discoloration of the skin? And then we move on to looking at the circulation. So, do they have intact pulses of the upper and lower extremities? What's the temperature of their skin? And then disability, you're really looking to evaluate the neurologic status of the patient. So typically in the emergency department, we do this by evaluating their GCS or Glasgow Coma Scale. And then you can also look at their pupils. And then exposure would be when you're taking a look at the skin. Is there anything that you're noting on the skin that's abnormal? This can include bruising, any signs of bleeding, or anything else. Then we move on to looking at the vital signs. So in particular, we're taking a look at their heart rate, their respiratory rate, their blood pressure, as well as their temperature. We always want to be putting these patients on continuous telemetry monitoring when they come into the emergency department with chest pain. Depending on what you're seeing when you're looking at the patient, you can consider putting them on the defibrillation and cardioversion pads just in case. And then you want to establish an IV in these patients. And then because we're in the emergency department, we always want to consider the use of point of care ultrasound. So this would be in particular doing a quick cardiac ultrasound as well as, taking a look at the lungs to see if there's anything that's sticking out to you in terms of that. So this could be if you're looking for a pericardial effusion, you can look at the functioning of the heart, you get a quick estimate of what their ejection fraction might be, and then see if there's any B lines that you're noticing on the lung ultrasound that might suggest that they are in a fluid overloaded state. The main thing that you want to kind of get a quick idea of is whether the patient is sick or not sick when they come in. And I think, this comes with time as you work in the emergency department, but you should be able to take a look at the patient and be like, okay, this patient is stable, or no, this is someone that I should be more worried about. And then, the main thing that we want to also remember is that all of these steps can be occurring at once. So you can have a nurse putting the patient on the monitor while you're getting some history from the patient and kind of doing your own assessment of the patient as well. So these are not going in order here. These are all things that can be happening simultaneously. So moving on to gathering a pertinent history from the patient. what we really want to focus on in the emergency department is getting a focused history from the patient. We really want details of what is bringing the patient in today. And if their symptoms have been going on, for example, for months, what is it today that changed that brought them into the emergency department? Sometimes I'm sure we've all had this experience where patients might want to share much more information than what we need in order to assess them at that moment. Sometimes they might not be sharing anything at all. And it really is our job as emergency medicine physicians to be able to get this story from them so that we can adequately treat them, and, try to figure out what might be going on. So questions I like to ask when patients come in particular with chest pain is, of course, starting out with what's bringing you in today, and then trying to get a better idea of what the qualities of their pain are. So where is the pain located? Does the pain radiate anywhere, such as to the back, to their jaw, down their arm? Can they describe the pain for me? Does it feel dull? Is it a squeezing pain? Is it a sharp pain? When did the pain start? Does the pain come and go, or is it pretty constant since it started? Is there anything that they can do that makes the pain either better or worse? What's the severity of the pain that they're experiencing, and does it stay at that severity for as long as they've been experiencing it? Have they ever had similar pain like this before? And then any other associated symptoms that they might have with the pain. So this includes, feeling lightheaded, feeling dizzy. Are they having any shortness of breath with it? Are they having any abdominal pain, any nausea, vomiting? Do they feel like their heart is racing in their chest or skipping a beat? Have they noticed any swelling of their legs? Any coughing up blood, anything that might help you kind of delineate what their chest pain might be from. And then this is a mnemonic that can be used to kind of keep these questions in mind when you're talking to these patients. So this particular one is Socrates. There are other ones that are available as well. So you're looking at the site of the pain, when did it start? So the onset, the character of the pain. So what does it feel like? If it's radiating, any associated symptoms that they might have, the time and duration of the pain, anything that makes it worse, as well as the severity. So essentially everything that we just went over, but this might help, in the moment when it's getting busy in the emergency department to kind of keep those questions in mind so we're not missing anything. And then, of course, it's always important to review the previous records if they're available for you. So this is a very valuable tool because it can provide you a lot of information that the patient either may not know or they might not remember either. So things that we want to be reviewing in particular for patients who are coming in with chest pain is any previous troponin levels that they might have and compare it to the troponin level that you've gotten today, any previous EKGs they might have, any previous chest x-rays or chest imaging that they might have. If they've had a previous echocardiogram, that's important information to take a look at. If they've had a previous heart catheterization, to look at that report to see if they've had any stents placed or any intervention that was performed. And then if they've seen a cardiologist, to one, note which cardiologist that they saw, but then also to take a look at the cardiology note to see if it can provide you any more information. And then, like I said, you're always wanting to compare the results that you got today with what the patient has had in the past, because sometimes that can provide a lot of helpful information.
Hey, Anisha, can we go ahead and pause here real quick, and just see if there's any questions? And, I will mention that for most of the docs on this call or participating have been practicing emergency medicine for a while. So maybe a question for the group, because I know this is kind of a really basic overview. Do you guys find that there are any good questions or things that you really like to start with when you have a patient with chest pain that helps you very quickly figure out if they have a scary diagnosis or they have a reassuring diagnosis like musculoskeletal pain. So I'll put it out there to the group. Does anyone have any questions that they really like to ask when they first meet a patient with chest pain? And how about I'll call on the group if we don't have anyone. How about Dr. Hung? Do you have any questions that you like to ask patients?
À, in in the emergency, soon we prepare for.
Perfect. Thanks, Dr. Hung. Does anyone else have anything they'd like to add? Well, I don't want to hold up Anisha's talk very long, but one thing I'll mention is I really quickly tried to figure out if their pain is exertional or not. I think Anisha will be getting to this as well, but when they've studied different types of data that help us figure out if this is a life-threatening cause or something more reassuring, a lot of times exertional chest pain or chest pain associated with syncope is much more concerning. So as I'm sure all of you feel like I don't have time sometimes to go through this full history with patients. And so just like Anisha mentioned, I think doing a focused one, and at some point I'd love to hear more about how you guys approach this. But Anisha, I'll turn it back over to you to keep going.
Sounds good. So when you're evaluating patients with chest pain, you always want to make sure that you have a differential diagnosis that's in mind. The main thing you're trying to do in the emergency department is trying to evaluate the patient for all serious causes of chest pain that could potentially kill them. So this does kind of build on the point that Shakira made, where if someone's coming in with, exertional chest pain, or if they've syncopized, or if they have any other more concerning symptoms associated with their chest pain, then that would cause us to kind of think that this might be something more concerning that is going on. Sometimes we won't have the answer by the end of our time with the patient, but the important part is to rule out any bad things that might be going on in a reasonable manner while they're in the emergency department. So the typical differential diagnosis that we tend to focus on, or at least try to rule out while patients are in the emergency department, is acute coronary syndrome. So this is, if they're having a STEMI, or if there's angina going on, if they have a pulmonary embolism, or if there's any risk factors for this. Aortic dissection is a big one. If they have a pneumothorax, and in particular, we become concerned if they have a tension pneumothorax, because that is more life-threatening. If they have cardiac tamponade, pericarditis, myocarditis, and then even esophageal rupture, which could present as chest pain as well. So those are kind of the main ones that we want to keep on our mind and try to rule out while we're evaluating the patient in the emergency department. So the physical examination, again, we want to make sure that we're always doing focused assessments of patients in the emergency department. So quick evaluation to aid in assessing the possible causes of chest pain on your differential. And of course, we all know that this goes well beyond just auscultating the heart. So in terms of the physical exam, things that I like to focus on is taking a look at the general appearance of the patient. So is the patient ill appearing? Do they look uncomfortable? Are they anxious? Do they look sick? Taking a look at the neck quickly to see if there's any bulging neck veins, or if there's any tracheal deviation, which might give us a hint that this is a tension pneumothorax going on. And then the pulmonary chest exam, looking to see if they have equal and bilateral breath sounds. Is their chest rise symmetric? Do they have lung sounds, or what do their lungs sound like? Is there any wheezing or rhonchi that are present? Any tenderness to palpation over the chest wall? And then is there any crepitus when you're pushing down on the chest wall? And then what is the rate and rhythm of their heart? Are there any abnormal heart sounds? Do their heart sounds sound distant? Do we need to be concerned that they might have a pericardial effusion or tamponade? The abdomen, is it tender? Is it soft or distended? Is there any pulsatile mass that you can appreciate that would make us more concerned for an abdominal aneurysm? When you're looking at the extremities, that's also important. Is there any peripheral edema that's noted or pitting edema? How do their pulses feel? In particular, looking at the radial pulse, the dorsalis pedis, and the posterior tibialis. And then the neurologic exam is important as well in chest pain, especially if you're concerned for an aortic dissection. So you want to evaluate both the motor function of the upper and lower extremities as well as their sensory, their sensation. And then finally, looking at the skin, looking at the temperature of the skin, the color, if there's any rashes or scars from previous surgeries, or any bruising that you're noting. In terms of orders, this is the EKG and chest X-ray are always big ones to get for patients with chest pain. You would consider getting a troponin level, getting a D-dimer, getting a complete blood count, a complete metabolic panel, coagulation studies, and then possibly getting CT imaging of the chest. Is there anything else that others would consider either getting on patients or doing as part of their physical exam? Popcorn, do you have any thoughts?
No, no.
No. Okay. See. Kong, how about you? If you're there.
I think in Vietnam is the same.
It's the same? Okay.
Anisha, maybe I can add in that
Yeah.
I do for chest pain, probably for chest pain and shortness of breath, are my two favorite complaints to do point of care ultrasound. So for those of you who have ultrasound in the ED, I think Anisha might be getting to this. I know it's thunder, but I would definitely consider, if you have it, doing your own ultrasound, which can pretty quickly help you rule in and rule out different diagnoses. So it's the only other thing I would add, but this list is really comprehensive.
And then just one more thing that we wanted to quickly go over, but we'll actually be discussing over the next couple of weeks here, are decision-making tools that we can use in the emergency department. So big ones that we use are the heart score for chest pain, as well as the PERT criteria, to see if you can be ruling patients in or out, for either getting a D-dimer on the patient to evaluate for a pulmonary embolism, which is the criteria that you're seeing over here, and then the heart score to see if this is a patient that has a low suspicion for having any acute coronary syndrome, or if this is someone that should be worked up further in the hospital by getting admitted. Do any of you use the heart score or PERT criteria in the emergency department when you're working and evaluating patients with chest pain? No.
Yeah, actually in the past I have used some time, but now it's a lot of patients, and actually when we do a small research.
Perfect. So you're familiar with them then?
Aisha, I'll jump into and say, for Kong, I'd be curious if you guys do this. We use it in where I practice, but to be honest, it's usually as a tool if we think the patient needs to be admitted to the hospital or needs more workup. We actually use it more when we're talking to the internal medicine doctors or the cardiologists to sort of advocate for whatever decision we probably already want to make. Like if we think the patient is high risk and we want to admit them and do a stress test, that's when I know that I use the heart score and I calculate it. Anisha, I don't know if you use it differently at all.
Yeah, that's essentially how I use it as well. Just trying to, you kind of usually have a feeling about the patients, but trying to one, advocate for your patient and then also kind of justifying if you feel like they can go home. This is a good tool to use, to see if you are able to do that. So just some key points to go over. Always start with your A, B, C, D, E vital signs, and then placing the patient on the monitor, and then always remembering that these are things that can be going on simultaneously. Obtaining a focused history from the patient, performing a focused physical exam, and then ruling out all of the life-threatening causes of chest pain. And then, we'll go into much more detail over the next few weeks for acute coronary syndrome and other causes of chest pain. But today was really kind of the overview of getting into the mindset of seeing patients with chest pain in the emergency department, and just some things to keep in mind as we go forward. Does anyone have any questions at this point?
Nisha, there's a great comment in the chat that Tribe put, and I can read it to the group. But I think that the discussion kind of around like how patients maybe should actually be divided into age groups because symptoms in older patients can be ambiguous and difficult to pinpoint. And then Tribe pointed out that careful attention and focus assessment are necessary to rule out potential conditions. And then thank you for Trang, who asked a question about how do we divide into moderate, high, or slight suspicion of history. So for Try, I think I can't agree with you more. I totally agree. Patients who get older are much more challenging to diagnose and also much more likely to have complicated medical issues. And then for the division history, Anisha, I'll defer that one to you if you have any comments or kind of how you divide into moderate, slight suspicion or high suspicion based on the history alone.
Yeah. So typically what I do, it really depends on how they're answering my questions for those questions that we went over for the chest pain. So if someone is coming in and they're having this like central chest pressure that doesn't get worse with palpation, it's been pretty constant. If they have any of that radiation that makes it more concerning either to the arms or to the neck and jaw area. If they have a history of coronary artery disease, that always makes their symptoms more suspicious if it gets worse when they're exerting themselves. So, unfortunately, there is some ambiguity in deciding if it's highly suspicious, moderately suspicious, or slightly suspicious, but using kind of your clinical judgment is how I go about doing that. And then, I very rarely will give someone a slightly suspicious, especially if they're coming in with chest pain, unless it's, a younger individual who has no past medical history and their pain is worse with palpation or anything like that, where it really does seem like it's not cardiac. That might be a time I would use that, but typically I'll err on the side of caution when using the slightly suspicious part.
Nisha, that was great. And actually, it's so funny. It's like you're repeating this verbatim. So I actually put in the chat the MD Calc link, and I also have the study which MD Calc summarizes. So for those of you who don't use it, MD Calc is a free online resource where you can actually calculate these scores. And if you look through it, it will actually link to the study article. So I actually put in there what the authors used when they created this scoring system. And basically, anything that counted, so they have a high and moderate risk symptoms. And if you have essentially one feature, it's moderate risk. If you have more than one of those symptoms, it was considered high. And then specifically, they had low risk features. And it's literally exactly what Anisha said, because she's so good at it. So I'll let you read it in the chat if you want more details. But feel free to take a look at that if you get a chance as well. And then Anisha, I think Hong asked a really good question is, what do you think about doing a second troponin, like a serial troponin? How do you decide when you want to do that?
Yeah. I typically, so again, it'll depend, this might be a time where I might use the heart score to help me with that. But I typically, if someone comes in with a story that sounds suspicious for coronary syndrome or acute coronary syndrome, I will be more likely to do the second troponin and make sure that it's not going up. Um, Anytime that your first troponin is also positive or slightly positive, that would be a time that I would trend it out as well. And just, this is also when taking a look at their previous troponin levels and their previous history becomes important as well to see if there's someone that is high risk for having acute coronary syndrome. So I tend to do the second troponin unless, again, it's someone that's young, has no past medical history, and your suspicion for them having something going on with their heart is very low.
And actually, if you don't mind, for those of you in the group too, I'll add to hers that a lot of it's on based on timing as well. So just a show of hands, does anyone at where they're practicing use high sensitivity troponins? Not yet. Okay, I'm not seeing any hands. So this is one thing that I think will be coming actually to Vietnam probably sooner rather than later. So remember there's two types of troponin tests. It's worth checking with your lab what you have. So the original kind of troponins were, it would take a little bit of time for you to see an elevation. So patients had to present, I think, within 6 hours. And if it was within 3 hours of the onset of their chest pain, you really needed to get a second troponin in order to definitively rule out acute coronary syndrome. We, in the past 2 years where I practice, now have high sensitivity troponins. So if a patient presents with chest pain and it started less than 3 hours ago, we can get one troponin. If it's completely negative, we have ruled out acute coronary syndrome, which is really nice. So it helps turn them around quicker. And we can actually get a second troponin. Let's say they just started having chest pain before they showed up. I can get one troponin. And let's say it's intermediate, I can get a second troponin. And if that's negative or stable, I can rule them out. So a typical chest pain workup for someone who you're moderately suspicious to be of normal troponins would probably take 6 hours, which is a very long time. And so a lot of places that can are starting to transition to high sensitivity troponins purely so you can discharge patients faster. So I'm going to go ahead and link in the chat. There's a free article from the American College of Cardiology that actually talks about high sensitivity troponins and actually includes an algorithm that includes when you should get a second troponin. So for those of you who are interested, feel free to take a look. It is kind of a long article, but there are some images and pictures that can be helpful too. Okay, thanks, Anisha.
So we're going to move on to the case study part of the presentation. So this is more of an interactive part, so we will call on you if we're not having volunteers. So essentially what we're going to do, over the course of the year is the first half of the lecture will be kind of this lecture part, and then we'll move on to a case study where we'll be going through the steps of seeing a virtual patient, and then going on to our practice questions at the end. So our case study for today is Mr. Smith. He's a 50-year-old male, has a past medical history of hypertension and smoking, who presents to the emergency department by ambulance complaining of the first time ever of having a severe crushing chest pain that just started while he was running on the treadmill. He called 911 immediately, which essentially means he called the ambulance. He's diaphoretic, so very sweaty, and he looks moderately ill appearing. He did receive nitroglycerin before he came to the hospital and had no change in his pain with the nitroglycerin. And then his vital signs for the ambulance before he got here was blood pressure of 140/90, pulse of 80, respiratory rate of 24, temperature of 98.3, and then an oxygen saturation of 98%. So what we're going to do today is kind of go through the step-by-step process of going through a case study so that hopefully we can build on this skill as we go through this month and then beyond. So the initial assessment of the patient, does anyone remember what we should be doing when a patient comes in with chest pain? The first thing we should be doing.
And you're also welcome to put your answer in the chat if you are in a place where you can speak, and I'm happy to let Anisha know as well.
Okay, so I think for this patient, we usually approach the ABCDE for patient first to make sure that
Perfect.
this patient is okay.
Yeah, that's great. Yep. So A, B, C, D, you got it. And then also the vital signs. And then, going on to the focused history of present illness. So all the questions that we went through earlier, and then the review of systems, which is asking any questions regarding any symptoms that they have related to their chest pain. So perfect. So these are our initial findings. So in terms of airway was intact. Patient is able to speak. Patient has bilateral breath sounds. They are tachypnic, so they're breathing a little fast. They have palpable and equal upper extremity pulses. Their GCS is 15. They are diaphoretic, so they're sweaty, but they do not have any rashes or lesions or any signs of bleeding that you're seeing. And then we put them on our monitor in the emergency department. And the vital signs that we initially get are a blood pressure of 143 over 92, a heart rate of 85, a respiratory rate of 22, oxygen saturation of 98%, and then their temperature is 37 degrees Celsius. So, what are some actions that we should be performing at this time for the patient? So this would be anything that you would do for the patient when they get to the emergency department, just based on their chief complaint. So what's bringing them in, and what they're telling you and what you're seeing. Any thoughts at all? So one could be that we would want to make sure that this patient is being put on a monitor when they get into the emergency department, so that you're starting that continuous monitoring of the patient. What's something else that you would potentially want to do when the patient comes in? Nia, do you have any thoughts?
Okay, if cancer comes to our hospital, I will maybe I will take an EKG and to perform an ultrasound first. After we take medical history and uh, take, I will do an EKG and maybe an emergency ultrasound.
Okay. Great. So some actions to perform when the patient comes in is one, putting the patient on the monitor. Depending on what the patient looks like, if you're thinking they're sick, in this case, I probably would, because they're having that crushing substernal chest pain, is putting the patient on the defibrillation cardioversion pads. And then assessing if the patient needs oxygen. In this case, their oxygen level was still within normal limits, so we could probably hold off on this for now. And then getting large bore IV access, so making sure you have an IV so that they can get any medications that they might need. Always getting a glucose level on patients that come in is helpful, and then any interventions that the patient might need at this time. So is there a need to give the patient pain medications? Are you suspicious for acute coronary syndrome? Do they need aspirin at this time, or is it okay to hold off? And then, of course, getting an EKG as quickly as possible and then a chest X-ray. So when we're doing case studies, it's always important to kind of verbalize and say all of these things so that we know that you would be wanting to get these studies going for the patient and perform these interventions and actions. So more history of the patient. So what are some things that we should be asking beyond just about their chest pain? What are some other important questions that we should be asking the patient? Hung, do you have any thoughts? So this is kind of going over more history from the patient after you've already asked them about their chest pain and everything. So you have kind of enough information about their chest pain. So what other information could be useful to you?
So I asked him about the time of onset of chest
Yep.
pain. Yes.
Yep.
Uh, yeah, what drug seems like use after um, attention, how long he use what medicine.
Mhm. Perfect. Those are all great questions, getting more information about their chest pain and then the quality of their chest pain, how long it's been going on. We also want to make sure that we're getting the past medical history of the patient, the surgical history, any allergies they might have, any medications that they might be on right now. All of this can give us good information as to, sometimes patients will say that they have no past medical history and then end up taking 10 medications, but they think that everything's controlled with their medications, so they don't think that that's a medical problem anymore. Their social history, so asking about smoking, any alcohol use, any drug use that they might have, and then any family history. So the family history is important because it can give you an indication as to what might be causing their pain, but also it's part of the heart score that we utilize. And you can't really complete using the heart score without knowing the family history. So that's always an important one for chest pain. So for this patient, they have a past medical history of hypertension, past surgical history. They've had their gallbladder taken out, no allergies that they know of. They take amlodipine, 5 milligrams for their blood pressure on a daily basis. The patient smokes 1 pack of cigarettes per day, no alcohol use, no drug use. And then his father had a heart attack at the age of 54. So moving on to the focused physical exam, what are some physical exam components that you want to make sure that you're doing for this patient? Popcorn?
Yeah. In physical exam, we take important intervention size.
So what
Uh,
are some things on the physical exam that you would be looking for in this patient?
yes, first, either vital sign. Yeah, wait me a minute. Yeah, the first important I think is the window side. We have to make sure the patient have not either hypotension or hyposemia, or we don't have the tachycardia, and we do some cardiac exam um, like we see the patient don't have the school cage at the heart and except the exchange release. Yep. Uh, mm, and after that we we exam the pulmonary exam and the trachea exam uh, at the same time. Yeah,
Perfect.
yeah. I
So
think it's the thing we can do for this patient. Yeah.
yeah. So essentially what you just said, we would want to look at how they generally look, look at the lungs, the heart, and then the extremities of the patient, what their skin feels like. A big one that we also want to do is the neurovascular exam, which is, the movement and sensation of their extremities. And then other ones to look at are the neck and the abdomen. So for this patient, the patient appears uncomfortable. They look anxious and they're diaphoretic. Their neck has no tracheal deviation that we're seeing. The chest is clear to auscultation bilaterally. There's equal and symmetric chest rise. There's no wheezing that we're hearing, no rhonchi, no ralls, no surgical scars that we're seeing on the chest wall. They're not tender to palpation over the chest wall, and we're not feeling any crepitus when we push down. Their cardiovascular exam, they have a normal rate and a normal rhythm. There's no murmurs. We're not hearing any rubs or gallops. Their heart sounds are not muffled and they're not distant. The abdomen is soft, it's non-tender, it's non-distended. There's no pulsatile masses and no bruising. Their extremities are well perfused. Their capillary refill is within normal limits. They have no peripheral edema, no pitting edema. And they have good radial pulses as well as pulses on their feet. And then their neurovascular exam is also normal. So what would be on your differential diagnosis for this patient? Keeping in mind that we want to kind of keep a broad differential so that we are not going down the hole of one thing that could be causing the chest pain and forgetting about other things that could be causing it. Louis, do you have any thoughts? Louis?
I think that we think about different diagnoses like acute coronary syndrome, pulmonary embolism, and tension pneumothorax.
Correct. Yeah. Anything else that you could add to that?
Um, Cardiac tamponade and pericarditis, myocarditis.
Great. Yeah, so those are kind of the big ones that we would want to be evaluating for. So, and perfect, we want to keep it broad. Want to make sure that we're adequately ruling these things out, especially if we have a sick looking individual. We want to make sure that we're kind of doing our due diligence in these. So acute coronary syndrome again, pulmonary embolism, aortic dissection, tension pneumothorax, esophageal rupture, pericarditis, myocarditis, and cardiac tamponade. And then for this patient, as of right now, what are some labs that we should be ordering, any medications that you might want to give the patient, and then any imaging studies that you might want to get. Trin, do you have any thoughts?
Yeah.
What are some lab studies that you would want to get on this patient?
Yeah. We need ECG, chest X-ray, troponin, D dimer, tablet, calculation studies, and finally maybe city Nichin if he complain of severe pain, chest pain.
Okay. Yeah, and the CT imaging we would get based on maybe some more lab studies that we get, such as a D dimer or based on our physical exam if we're thinking about dissection. Great. Okay. So exactly what you said. So we would want to get a CBC, a CMP, a troponin, a D dimer. These are things that we would be considering using our clinical decision rules for. So for example, the PERC criteria. I usually get coagulation studies on these patients in case they need to get anticoagulation. Then, like you said, an EKG, a chest X-ray. Our point of care ultrasound in the emergency department is always important and can provide a lot of valuable information. And then we can, again, consider pain medications depending on what the clinical scenario is. So this is our EKG that we got for the patient. So can anyone tell me what they're seeing here? That's not a trick question.
Looks bad in this case. Did anyone else has the diagnosis?
Kong, any thoughts?
Yeah, we can see the activity elevated in the V1 to V5, and it's the yeah, I think we can see the myocardial infection.
Great. Perfect. So this patient has a STEMI, right? Perfect. And so this is their chest X-ray that we had asked for. It looks normal. So there's no widening of the mediastinum. There's no signs of pleural effusion or fluid overload or anything. So great. So further actions for this patient. At this point, because we see that they're having a STEMI, if we haven't done so already, we would give them aspirin, so 324 milligrams of chewable aspirin. We could give them a heparin bolus, put them on antiplatelet therapy, and then call cardiology or activate the catheterization lab. So at this point, I did want to ask a question. When a patient comes in and they have ST elevation that you're seeing on their EKG at your hospital, what would be the next step at that point for you? Fine. What would you do if this patient came in and you saw them in the emergency department?
Yeah, when the patient have the diagnosis with the STEMI, we will immediately control the vital sign, and we give the patient some medication. Is the aspirin depend on the sometimes we have more medication, sometimes it's just aspirin, and then we
Okay.
will call the cardiologist and transfer the patient to the cardiologist in 3 to 5 minutes.
Oh, wow. Okay. So fast turnaround time. Okay. Is there anything else that anyone else does at their hospitals that's different? Or is it pretty much just trying to get the patient the care that they need as fast as they can? All right. So I know we're running out of time here. I did just want to go over at least one of these practice questions, just so you can get an idea as to what we'll be doing over, the coming year. So we'll go over this one over here. So I'll read it out loud. A 34-year-old woman presents to the emergency department after 5 episodes of crushing substernal chest pain that occurred while she was watching TV. These episodes have occurred every morning for the past 4 days. Each time, the pain spontaneously resolves after 20 minutes. The patient has no medical problems. She does not smoke, runs 3 miles daily, and has no family history of heart disease. In the emergency department, the patient experiences another short episode of pain. An EKG obtained during the event shows ST segment elevation, which resolves within a few seconds of her pain resolving. The patient is observed in the emergency department and her troponin returns as negative. Her vital signs are a blood pressure of 132/84, a heart rate of 86, respiratory rate of 16, and oxygen saturation of 97% on room air. Typically, I didn't do this for this question, but typically I'll start with reading the last part of the question stem first. So, which medication can be used to treat this patient's most likely condition? So, does anyone have any thoughts? Peng, how about you?
You guys are also welcome to put your guess of an answer in the chat if you want as well.
Does anyone have a guess for this question? Trin? I know we're at our end of our class here.
I think I use aspirin.
Aspirin?
This.
Okay.
Yeah.
Okay. So let's take a look to see if that's right. So it's actually C, diltiazem. And the reason for that is because this patient, they're saying, has ST elevation that comes about for a couple of seconds. And then when her pain goes away, her ST segment elevation goes away. So what we're seeing here is the condition called transmental angina. And typically what this is a spasm of the coronary artery that will cause decreased blood flow for those couple of seconds that the spasm is occurring, which leads to the ST elevation that you see on the EKG at that time. So this is not a true STEMI that we're seeing, and we'll put these patients on a calcium channel blocker to help with their vasospasm. So I do have other questions, but I know it's the end of our lecture here, so we'll kind of hold off on these questions for today. Did want to just say thank you for everyone for joining us today. I'm really excited for the next month and then also for the coming year. Does anyone have any questions at all at this time before we let you go for today? And then you're always welcome to put it in the chat as well.
In Vietnam, we use morphine in the for the chest pain.
What's that? Sorry.
We use morphine for patient in chest pain.
In chest pain, yeah, you can definitely do that. Yep.
I would say that was a really tough question because I think that patient could probably benefit from aspirin and morphine and all of the medications too. So that was a challenging question. And I got to be honest, I think if I saw this patient in the ER, I might miss this diagnosis myself.
Yeah.
Not anymore after I know this now, but before this as well.
Okay. All right. If anyone has any questions, after the lecture, you're always welcome to email me or any one of us as well. But again, thank you for being here, and we'll see you next week. And I'll send out an email for next week's lecture at some point over today. All right.
Thank you,
Thank you,
y'all.
everyone.
Hey, Anisha, if you have 2 minutes, do you want to stay on for a second? We can do a quick
Sure.
chat.
Yes.
Bye, everyone. So great to see you all.
Bye.
So thank you all for interesting presentation, and hope you see you next week.
Yep. See you next week. Thank you.
Okay.
Thank
See
you.
you next week.
Thank you.
Bye.
Thank
Bye.
you.
Thank
Bye.
you.
Bye.
Anisha, what if I send you a separate Zoom link? Is that not okay?
Yeah.
We can jump off. Okay, I'll send you one in like 2 seconds to your Gmail, then we could just jump off this. Sound good?
Okay. Yeah,
Okay.
sounds good. Okay.
Ông nội, đó cái gì nữa không? Thì mấy ông bạn ổng vậy bụng luôn á. Nó mới dắt ăn trong nè. Nó không thấy vậy chắc nó lén đưa đâu biết rồi. Nó không biết nữa. Dùng cái kính này không, tôi xuống đó nói chuyện đi, để nó không la, quen mẹ quá rồi. Nghe. Còn cái kia đem muốn trình cho trình 2 cái luôn được. Cái đóng góp á. Xong chưa? Đang gõ lại. Xong chưa? Mới bắt đầu gõ một tay hơi lâu. Không rồi. Gõ một tay hơi lâu. Xuống trình một lần chứ thì là em ơi chủ đề trình một lần chứ gợi nhắc không mà trời. Người coi cái 32 sao mà trình nói nha, nó mới nhắc nữa là hướng thị luôn á. Nhắn rồi hả? Nó cũng này cái bình tĩnh ruột đó, anh lên ruột nha. Có ý nghe Thành? Cái nào lên? Đây còn đó cũng được rồi đi. Ông lên sách đi rồi nha. Đi
Dạ.
lên rồi đó.
Mình đúng rồi, là mình sẽ nói về, mình sẽ chấm tiêu chí nào anh?